The title of this talk is Memory Classification. The classification of memory is complex, and there's no one classification fully congruent or universally accepted. The objective of this talk is to put forward a memory classification that applies to clinical practice while keeping pace with recent trends in the field. I think that you will get more from this talk if shortly after finishing this video you view the video on memory models. This talk will be conducted in a question and answer format. First question: there's only one type of memory, A true, B false. Memory can be partitioned in three divisions: immediate recall, tested by asking a patient to immediately repeat a set of digits as a telephone number or repeat a set of nouns such as apple, book, and chair. Instant recall can be classified as unencoded memory. Unencoded memory are easily forgotten. The second division of memory is working memory. Working memory is also an unencoded memory. Working memory has three specifications. Two are time-related. One relates to quantity. I will first address the time-related specifications. The first one is that working memory holds information not currently being used for just about 20 seconds and no more. I give you an example. If a patient starts coloring a square with a green pencil, then goes to a different square in another page, no longer being able to see the first green square painted, and there he uses a blue pencil, then the patient is told to color another square using the same color as was used for the first square, but the color of the first square is out of sight, as we have previously stated. Working memory would allow the person to remember the color first used, in this case green, if the time using the blue pencil is 20 seconds or less. The second time specification is that working memory holds information while performing mental operations using the information indefinitely. I will give you an example. If a patient starts coloring a square with a green pencil and then goes on to another square, no longer being able to see the first square, but continues using the green pencil, that patient would remember that the first square was painted green even when going to paint another square in a different page. The memory that the first square was painted green would be kept for 1 hour, 2 hours, or longer. In this case, the recalling of the first color use is kept at the working memory. Those are the two time-related specifications for working memory. The one quantity-related specification for working memory is that working memory only holds 7 to 9 items of information. Working memory and immediate recall have three things in common. The information kept in these memories is not encoded. The information is kept in the cerebral cortex, and the information is disregarded shortly after its continuous use stops. Long-term memory is rather different. Long-term memory is encoded. Long-term memory has two specifications. One is time-related. The other one is quantity-related. The time-related specification is that long-term memory holds information even after it has not been used for longer than 20 seconds. The second specification relates to quantity. Long-term memory holds way more than 9 units of information. So the answer to this question is false. Next question. Long-term memory can be classified using time. Long-term memory can be classified in 4 ways. According to time, according to the process involved, encoding or retrieval, according to it being affected or not affected in patients with amnesia, and according to the anatomical location where memory is stored. We will start by talking about the time-based classification of long-term memory. According to time, memory can be classified as recent, implying unconsolidated memory, or remote, implying consolidated memory. Recent memory and remote memory have no precise time boundary. In clinical practice, we test recent memory by asking about autobiographical events, facts, or skills learned in the last 24 hours, and remote memory by asking the same type of questions, but regarding events, facts, and skills learned many years before. So the answer to this question is true. Next question. Long-term memory can be classified according to the process involved. The second way we can classify long-term memory is based on 2 of the processes involved in long-term memory. These processes are encoding and retrieving. Encoding is a complex function which is discussed in another video. At this junction, let's just say that encoding can be compared to burning a computer disk. That is, the recording of sights and sounds. Retrieving is a function of transferring a long-term memory to working memory, so it can be communicated or displayed. It is similar to playing back the disk previously burned. Based on this function, we can classify memory as anterograde when the disk is being burned, and the long-term memory is being built. An example is signing a document now and remembering that you sign it 1 minute later after you put the pen down and drink a glass of water. When this process fails, no new long-term memory is acquired. An example is signing a document and 1 minute later, after putting the pen down and drinking a glass of water, forgetting you did. The second division of memory, pivoting on the process being used, is called retrograde. It is the equivalent of playing back the sounds and images burned in the disk. An example of retrograde memory is remembering the brand of your first car or what you have for breakfast. When retrograde memory is not working, a situation called retrograde amnesia occurs. This implies that things are forgotten, such as the brand of your first car or using a hammer if you work as a carpenter when you were young. So the answer to this question is true. Next question. Patients with amnesia forget all recent long-term memories. A true, B false. Long-term memory can also be classified in a third way, according to it being spared or affected in patients with amnesia syndrome. Amnesia syndrome being defined as a memory problem due to purely hippocampal dysfunction with a normal MRI of the brain. Using this criteria, memory can be classified as explicit memory, which is always affected to some degree in patients with amnesia syndrome. Explicit memory requires hippocampal involvement for encoding, and it is stored in the cerebral cortex. Explicit memory is consciously recalled and can be expressed in a declarative statement. Hence, it is also called declarative memory. I have placed the asterisk here by the word explicit to emphasize that declarative memory is always dependent on mental effort. The other arm of this classification is implicit long-term memory. Implicit memory, using the current method of testing in clinical practice, is never affected in patients with amnesia syndrome. It does not need hippocampal involvement for retrieval, and it is stored in multiple CNS locations, not only in the cerebral cortex. Implicit memory cannot be expressed in a declarative fashion. Hence, it is also called non-declarative memory. So the answer to this question is false. Next question. Explicit memory can be episodic or semantic. Explicit memory can be divided into semantic. Semantic memory refers to facts that most people would know, that is, to genetic knowledge, so it is often called genetic memory. An example of this type of memory is citing the capital of France. Questions to patients regarding semantic memory should be as open-ended as possible. For example, it is better to ask them to tell us the names of the capitals that they recall than to ask them to tell us the capital of France. The reason for this is twofold. The patient may not know the capital of France, and more importantly, you want to avoid priming, that is, you want to avoid giving clues that would jog specific memories. Episodic memory, the other division of explicit memory, is autobiographical. It stores what, when, and how things that happen to the patient are remembered by the patient. Hence, you often need to corroborate with family members or friends their information. Episodic memory allows the patient to live an episode of their lives over and over again. Episodic memory is often referred to as contextual memory because it is perceived in the context of the patient's own experience. An example of episodic memory is, I had an egg for breakfast, and I was happy the day my daughter was born. Again, try to ask the patient open-ended questions such as, what do you remember from this morning, or what do you remember that happened 20 years ago, instead of specific questions. So the answer to this question is true. Next question. Priming is a form of implicit memory. Implicit memory can be divided in non-procedural and procedural. Procedural memory implies memory of routine activities, memories of how to do things that have been done many times for many years. For example, how to ride a bike. To the side of the term procedural memory, I have added 2 asterisks to emphasize that such activity usually requires no mental effort. Non-procedural memory, the other division of implicit memory, to which I have added a cross to emphasize that such activity is achieved without awareness of mental effort, always. Non-procedural memory can itself be divided into 5 types. The first type is priming. Priming consists of completing an activity based on clues provided. Asking the patient to complete an incomplete drawing of a cup. Normally they will do so. Or presenting a word with a missing letter and asking them to complete it. Normally they will. The memory retrieval that allows completion of a known figure or word is a pure cortical phenomenon, but it is likely, almost certain, that the initial acquisition of the knowledge that allows the completion of the task, that is the encoding of the knowledge as a long-term memory, requires hippocampal formation involvement. So the answer to this question is true. Next question. Being afraid of a snake is considered an emotional memory. A, true, B, false. The second type of implicit non-procedural memory is sensitization. I will give you an example. If a bell is ringed, a trained dog will come. If you then hit the dog will run away. Next time you ring the bell, the dog will come. If you hit the dog again, the dog will run. If you do this many times, when you ring the bell, the dog will run. This is a photograph of Dr. Ivan Pavlov doing surgery in a dog. You can also see in this frame a portrait of one of his dogs and a white coat. I included the white coat because it was Pavlov's observation that the dog salivated at the sight of the white coat used by his assistants, the one in charge of feeding the dogs. Whether his assistant was bringing the dog food or not, that made him think of his classic experiment. In this case, the dog had inadvertently been trained to expect food after seeing a white coat. The third type of implicit non-procedural memory is habituation. The best example is that you do not feel your clothes while you are wearing them. The fourth type of implicit non-procedural memory is referred to as somatic. An example of somatic memory is the man that gets hit in the head and becomes dizzy, and next time he sees someone getting hit in the head, he becomes dizzy. The fifth type is called emotional memory. An example of emotional memory is the man who sees a snake and feels fear, or the pain in the heart this poor fellow felt after seeing his old girlfriend with someone else. Of all the non-procedural memories, the only one tested in clinical settings is priming. But historical complaints occasionally involve all the four types of non-procedural memories. So the answer to this question is true. Next question. Long-term memory can be classified according to the alleged location where the memory is stored. A, true, B, false. Long-term memory can also be classified according to the alleged location where the memory is stored. But this classification is even more controversial than all the other three classifications we have already spoken about, and like all others, lacks universal approval. In this new frame, I have included 3 brain specimens to list the alleged stored locations of the different types of memories. Priming memory, brought about by asking the individual to complete a task, as well as semantic memory and episodic memory, are stored in the neocortex. Semantic memory and episodic memory are also stored in the archicortex of the mesial region of the temporal lobe. Procedural memory, how to ride a bike or how to type, is stored in the neostriatum, that is in the caudate and the putamen. Somatic memory, recalling your physical pain after seeing someone else going through the event that caused your pain, is said to be stored in the cerebellum. Sensitization and habituation is said to be stored in the brainstem. Emotional memories are stored in the amygdala. The prefrontal cortex, especially in the lateral surface, has the executive function for all memories, especially for those stored in the cortex, that is in the cerebral cortex, and for those stored in the neostriatum, and also to a lesser extent for those in the cerebellum, and it has little control or no control at all for those stored in the brainstem. So the answer to this question is true. Next question. In patients with amnesia syndrome, episodic memory is less affected than semantic memory. A, true, B, false. The clinical manifestation of amnesia syndrome, defined as amnesia in the absence of any other mental illness in a patient with normal MRI of the brain, usually consists of anterograde memory lost, which preclude the patient from learning new information or task, although to my knowledge no one has tested if a patient with amnesia syndrome can learn to ride a bike or type. Involved in patient with amnesia syndrome is explicit memory. Episodic memory, one of the 2 types of explicit memory, being most affected. Recently lived experiences are not recalled to a larger extent than those lived far in the past. When it is the other way around, recently lived experiences are recalled, while earlier experiences are not recalled, the diagnosis of amnesia syndrome should be in doubt. Semantic memory, general facts such as naming the capital of France, is less affected and in most cases not affected at all in patients with amnesia syndrome. This may reflect that most facts stored in semantic memory were acquired early in life. implicit memory as tested by priming is not affected. So the answer to this question is false. Thank you very much for your attention.